Hello, my name is Joseph Tronzo. I'm a colorectal surgeon at the Cleveland Clinic here in Cleveland, Ohio. I'm going to be giving a discussion on malignancies of the colon, rectum, and anus. And in this discussion, I'm hopeful that we'll get some insight on screening, surveillance, treatment of colon rectal cancer, and obviously the surgical interventions that we offer as surgeons. I have no disclosures with this talk. Just a little background, at least our objectives for my planned discussion. I'm going to give a little background on colon rectal cancer as well as anal cancer. I highlighted a couple of groups at the Colon Cancer Alliance and the HPV and Anal Cancer Foundation that support those two cancer diagnoses. As I said, we're going to go through some screening process of colon rectal cancer. We're also going to discuss staging. I plan for treatments, both surgically and medically, and then some survival statistics, and I'll try to bring up some recent survival statistics for your review. So to discuss these two entities, colon rectal cancer as well as anal cancer, those are, separate in the way they're treated, their diagnosis pathologically, and so I'm going to sort of break up the discussion in sort of two parts, focusing the majority of my discussion on colon and rectal cancer, and then at the end of the discussion will be a little bit of a briefer discussion on anal cancer, and sort of talk about them differently in two different settings as they are sort of separate entities. So just a little background on colon and rectal cancer. It is the fourth most diagnosed cancer that we see annually. It is second leading cause of cancer death in the United States, second only to lung cancer. And then the third most common cause of death is prostate in men and breast in women. And looking at the current reported statistics from the National Cancer Institute, in 2018, they estimated approximately 140,000 new cases of colon rectal cancer and deaths of just over 50,000. It poses a lifetime risk of 4.5% to all comers, both men and women. And again, looking at the National Cancer Institute statistics, it represents 8% of new diagnosis annually in the United States. And then, as you can see, the fourth leading diagnosis that we see annually. So at the beginning of any colorectal cancer talk, I think it's important that we understand one of the foundations of treatment in colorectal cancer is prevention, as it is a highly preventable cancer if we're able to screen for it. There's a lot of screening tools that we use, some better than others. And I think it's important that you're aware of what is available to our patients and what we are using routinely and what are the recommendations for proper screening. So we're going to start off with kind of go right at it with, who should be screened. And when we look at the patients that we consider average risk or normal risk without, significant personal or family history, American Cancer Society put out a publication just this past year in 2018, and it was a landmark paper that lowered the risk or the screening age to age 45. And the screening age had been 50 for quite a long time now. And after looking at the statistics and what we've seen is a much younger population of patients being diagnosed over the course of time, that it sort of posed this discussion and reevaluation of where we are with our screening criteria. And this is a big step in the right direction to lower the screening age and make earlier diagnosis and obviously hopefully lower the diagnosis of colon rectal cancer. And then when I take a look at their graph from their paper, we have looking on here on this line graph, what we saw is leading up to this point, African-American ethnicity had already posed a bit of a younger group of patients that diagnosed colon rectal cancer, and their screening recommendation had been 45 for some time now. But we see in the Caucasian or white ethnicity that bar or that line over time had stayed well below and then has now creeped up and almost parallel to that of the African-American population as of recently. And with that, one of the recommendations that came out of that was because of this change in the prevalence in the younger age population all across the board, and again driving that recommendation down several years. And as you can see at the end of the graph there. So looking a little more just at this paper, spending a few minutes on it, as again, when we do look at this line graph over the course of time, in the younger age group, this top line graph is from age 20 to 49. This is coming out of that same publication. We've seen a steady increase in that younger age group with earlier with incidence and increased incidence over time. And then inversely to that, we've seen in those above the age 50 group, there's been a steady decline over the course of time. And how we are able to validate that is we've had increased awareness, we've had increased screening and prevention. We've also discussed lifestyle modifications. And in that higher age group where we were making those changes and we're increasing that screening and awareness, we're actually seeing a decline in diagnosis. But where that group is falling out of favor is that younger group where we're not screening them as early because they don't have the history that would pose us to screen them. And we're seeing more and more diagnosis. And certainly there's some environmental factors. There's got to be other factors involved that is driving this earlier diagnosis, despite our efforts with the 50 and above age group where we're seeing some improvement. So going back to who should be screened, the recommended screening should occur starting at age 45, and it's recommended to be continued on to age 75. There's no recommendation for screening after age 50. There are certain select cases in which we will do that based on patients' symptomatology and their clinical condition, but there's no general screening that's recommended beyond 85. And then that group in between 75 and 85, it's taken sort of on a case-by-case basis, depending on the patient's health, their overall life expectancy. Could they tolerate an operation for colon cancer should their diagnosis be made? So certainly all of these factors play a role in our decisions to pursue screening beyond age 75. So who is at increased risk? Certainly, there's a wide category of patients that fall outside of the average risk, and those that certainly if they've had a diagnosis of colon cancer, prior history of colon polyps will continue to pose an increased risk. Cancer of the uterus, ovary, and breast in females, and that kind of goes along with some of the diagnosis for polyposis type syndromes. But we do see a correlation even in non-polyposis type patients that they've had gynecologic cancers or breast cancer that they should have earlier screening. Certainly inflammatory bowel disease chronically will increase overall life expectancy risk of colon and rectal cancer. Exposure of the abdomen or pelvis, and thinking about those cases, patients that have had cervical cancer and pelvic radiation, they have an increased risk, as well as in men, you can think about external beam radiation for prostate cancer as a potential risk. And that would be sort of the younger population that would push us to start looking earlier. And type 2 diabetes is something that has been more recently been looked at as another personal risk factor for increased incidence, and consider earlier screening in those cases. Without spending too much time on this, these are a bit more obvious, but certainly family history of colon rectal cancer. And when we talk about this who falls into that category, certainly first degree relatives under the age of 60, 2 first degree relatives of any age. And that first degree relative means brother, sister, mother, sibling. And the recommendation is going to be that they start screening 10 years prior or begin at age 40, and that's whichever is younger. So if 10 years the patient had colon rectal cancer, or the mother had colon rectal cancer at age 55, 10 years prior would be 45, but you'd still begin screening at age 40. Sort of outside the potential for increased risk, they're still considered average risk, but if you do have 2 second degree relatives, meaning grandparents, aunt, uncle, they still would recommend screening beginning at age 40 in those patients. And then certainly, as we talked about briefly, the familial polyposis patients, and I'm not going to spend too much time on that, which is a very more complicated, in-depth conversation on familial adenomatous polyposis syndrome, FAP, Lynch syndrome, and certainly MYH associated polyposis as well. So one other category I want to just real quickly touch on is the modifiable risk factors that go along with it. So what we've seen over the course of time is smoking, alcohol, dietary choices, including high in fat, red meat, low fiber diets, patients that are not active, and overweight. These are all risk factors statistically. We've seen these patients are showing up with colon cancers, and it's not one factor alone. Certainly, it's a combination of things, but these are all things that are modifiable in our patients, as opposed to some things that are not modifiable, meaning their family history and their medical history, such as diabetes. And then just a last sort of slide discussion on, patients' complaints, obvious things of blood in the stool, hematochezia, melena, change in stool caliber and frequency. These are all signs that something potentially would warrant investigation. One of the things that people are not as much aware of is this concept of tenesmus, and that's discomfort or urge to defecate with very little evacuation. Sometimes it's mucus. If patients have these complaints, they'll come to their primary care doctor about them. We see this kind of complaint very often with rectal cancer. So that's another sort of symptomatology that may or may not trigger a discussion about, is there something more going on colorectal malignancy-wise or neoplasm-wise that would need to be addressed. And certainly unintentional weight loss across the board for any malignancy is certainly something to be concerned about. So talking about the age group now, the next concept is what are the screening tests? What are we offering patients to screen them? And I sort of broke these down in sort of two major categories of discussion. One of them being whether the patient would require bowel preparation, one that does not. And there's pros and cons to both. And certainly one of the things that impact people's decision to have screening, especially creatinine colonoscopy, is that concept of the bowel preparation. And I'm not going to spend a lot of time about the different types of bowel preparation, but that is one of our barriers that we have to educate our patients about and overcome to increase our screening because of this resistance to go through having to go through a bowel preparation. So I'm going to start right out of the gate with, the standard screening tool that we use across the board is certainly colonoscopy. With it comes the highest detection rate for polyps, and certainly is for diagnosis of malignancy. The benefit of the colonoscopy is it's not just diagnostic, it's also therapeutic. As we see polyps, we try to remove them. If we see a malignancy or we see a mass, we're going to biopsy it, so we're able to intervene with the findings on the exam. The also benefit is that if you do have a negative colonoscopy and don't have risk factors, your screening can be stretched out to 10 years. There'll be other reasons why it would be shorter, but that's one of the upsides to doing the screening, and some of the tools that we can use in our toolbox to get patients to accept the fact that colonoscopy is part of what they need to do with their overall health and maintenance. Certainly the downside to it is the bowel preparation. There is obviously the small risk of complication, perforation, bleeding, and this is a rare complication, but it's a real complication when it does occur. And the concept of needing sedation. Patients that have a lot of medical comorbidities, the sedation is part of the treatment here, or the diagnostic screening tool here, and that may be prohibitive for some patients, and may have to consider other options if that is such a barrier. So this is one of the main reasons. These cons are the reasons why there's so many other available tools for screening, and we're going to talk about this. I think that a lot of patients surgeons are not as familiar with all of the different screening tools and when they should be used and how often they should be used. So we should be just as aware as the primary care doctors about what's out there and what patients are utilizing for their screening. Now, the tried and true sort of technique in testing is fecal occult blood testing, which is still available, and it's certainly not invasive. It's something they do in the comfort of their home, swabbing a stool sample onto a card and sending it in to be tested. It needs to be done annually. It's not as specific. Certainly, there are a lot of things in our diet that can cause false positive. There's certain vegetables, red meats. So when you do take this test, you have to be on a very restricted diet so that there isn't to lower that risk of false positivity. And certainly, there's a miss rate there. They're not going to detect polyps, especially benign polyps, unless they're large enough or likely advanced enough that they're causing enough bleeding to be detected on this. And obviously the downside of it is if it's positive, then you're ultimately willing going on to colonoscopy and requiring that anyway. More recently, the fecal occult blood test has been replaced with the fecal immunochemical test, which is the FIT test. This uses antibodies to detect the blood in the stool. It's very specific to blood from a colonic source. It is certainly not invasive. You do not need a bowel prep, and you do not have the dietary restrictions that go along with the occult test. There is some polyp detection. It is better than the occult test. Certainly, they have to be, again, larger polyps. That's going to potentially shed some blood into the stool. It's going to be picked up. Smaller polyps are less likely to be detected on this FIT test. It is required annually. It does, again, both a higher specificity than the fecal occult test, but again, it's not very high yield on smaller polyps, and certainly trying to get to one of the reasons why we encourage colonoscopy as the primary screening tool is that we are able to prevent colon cancer by eradicating polyps before they become advanced polyps or certainly turn to invasive disease. The last sort of discussion that we're going to talk as far as screening tools is the FIT DNA test, which is, I'll have one other thing after this, I apologize. But the non-invasive treatment here is the FIT DNA Cologuard, which is more of a newer screening tools that are available to patients. It is a good test in that it has a much higher detection rate for both benign polyps and malignant disease, as it picks up DNA in the stool. It does require the patient to have a full bowel movement in which it is actually contained in a sealed container and is mailed in to be assessed. But again, the sensitivity and specificity is very good. Obviously, it is non-invasive. You do not have to take a bowel preparation, and it bodes a suggested every 3-year assessment of the colon, as opposed to the annual assessment that's needed with the occult test and the FIT test, the non-DNA form. Certainly, the downside is the stigmata of having to mail in a bowel movement. I mean, that certainly is a barrier for people to get around. But there are folks that are very strongly against having colonoscopy, and this is a reasonable tool. It is not widely accepted from an insurance payer standpoint. Not all insurance payers will support this. So that is a barrier. So you have to check from a person-to-person basis on this. And it's not quite as sensitive, of course, as a colonoscopy, and certainly a positive result will ultimately require colonoscopy. And then again, I apologize. This will be the sort of last discussion on the screening portion, and the imaging screening tools that we have available to us now was previously just barium enema, but really has been transitioned over to CT colonography, or patients commonly call the virtual colonoscopy. It's becoming more readily available. The CT scanners are very sensitive to doing it. In certain centers, they have a more availability to our patients to have this done. It's certainly less invasive than a colonoscopy, but in the setting of CT colonography compared to colonoscopy, it is very good at picking up small to medium polyps. Very tiny flat polyps are less likely to be detected, but certainly has a high sensitivity. It is better than CT colonography is better than barium enema, which really has fallen out of favor comparative amongst the two type of imaging modalities. It still requires a bowel preparation, and some people don't recall that or don't seem to understand that, that just because they're having the CT scan they're gonna avoid having to do the bowel prep. That's not true. They do actually have to have a bowel prep, just the way you would for a colonoscopy. As I mentioned, the detection rate for smaller polyps is still slightly inferior to colonoscopy, but giving the high sensitivity that still resides with it, if you do have a negative CT colonography, they do both give you a 5-year interval between when you need to have your next one done. There are some barriers reimbursement-wise that Medicare does not reimburse it primarily, to my knowledge. As a secondary test for a failed colonoscopy or inability to do the colonoscopy, that's where it becomes more of a utilized tool, at least in my practice as well. If the patient could not tolerate the colonoscopy or there was some technical limitation that prevented us from completing colonoscopy, this is a better secondary procedure. And then the downside, again, if you're using this as a primary tool, because patients are so adamant against the colonoscopy, is that if a finding is there, then they're most likely, they will need a colonoscopy and a second bowel preparation, because it's very unlikely that they're going to have a colonoscopy on the same day of their CT colonography that is performed. So just a sidebar as far as kind of discussions with the patients that you can have if you're going to have, try to sway them one way or other. I think that's a reasonable thing to help educate our patients. So moving on from the screening component and on to the staging of colorectal cancer. And I think it's important as surgeons to have a good understanding for colorectal cancer staging, because many of the times in my practice, I am going to be completing a lot of the staging workup. Our treatment is dictated many times by the staging. So having a good understanding of the colorectal cancer staging, especially if you are performing oncologic surgery, I think is important. So to begin, we'll talk about the staging imaging. It's fairly straightforward. CT scan of the chest, abdomen, and pelvis with IV and oral contrast is the recommendation. Our recommendations that I discuss here in the staging segment of our lecture are all through the National Cancer Guidelines, the NCCN guidelines. And these are all readily available to physicians for review. And I encourage you to utilize that tool on their website if there is a question about staging or there is a question about standard of care treatment. And that's a good tool for you to kind of fall back on when there's concern about where they should be or how they should be followed. And again, there are patients that fall out of that, all the categories there, but certainly a place to start. Many times, and again, this happens again in my practice, that the patient will have a diagnosis of colon cancer, and they immediately were sent to have an abdominal pelvic CT done, but they've come and they didn't get the completed CT of the chest. So the question always reads, well, do we have to send them back to get another CAT scan done, give them more contrast? And the answer to that is based on the guidelines, they can have a non-contrasted CT if you do not want to retest them again with the contrast. It is still recommended by the NCCN that they do have a completed chest CT as a baseline. However, historically, chest X-ray was the chest evaluation that was done with our screening. And they actually looked at this several years ago and found that when chest X-ray was done in a setting of no evidence of metastatic disease in the abdomen or pelvis, that the chest CT compared to the chest X-ray did not bore out new information that was not detectable on the X-ray. So still a little bit, if you look at it, it's a bit controversial about whether chest X-ray is adequate enough, but I will tell you in practice, having the chest CT as a baseline when you start their treatment, it actually works well looking forward as it has if you're during the surveillance time and they're getting repeated scans, picking up new information that may or may not have been there. It's always better to have a baseline start, and I think it's important that we try to stick to the NCCN guidelines. So across the board, we're providing that same care from one institution to the next. One of the always concerns is the patient can't have IV contrast. They have renal insufficiency. They have other medical comorbidities that prevent it, or they have IV contrast allergies. You can, as a secondary stage, again, out of the NCCN guidelines, as a secondary treatment, or imaging staging, they can use MRI, and then PET scan is a sort of a third line agent. PET scan is not routinely used in colorectal cancer as part of the staging protocol. So if you're to that point, certainly involvement of your oncologist and other things probably is going to be a benefit. And one of the things that we always are concerned about is these indeterminate liver lesions, especially with the technical ability of the CT scanners to find small little nuances in the imaging. These indeterminate liver lesions are many times picked up, and they do need to be followed. So the recommendation is prior to treatment, they should have a preoperative MRI, and that's more definitive for looking at those indeterminate liver lesions, and that would help us with staging, to be definitive staging, and then potential whether or not if this is stage 4 disease with malignancy to the liver, whether or not that's going to also need intervention. Stage 4 disease is potentially treatable surgically and medically. But again, it's always good to start with a baseline and know where you are. Sometimes these indeterminate lesions, even though the MRI cannot be, or even though the imaging may not be conclusive, Those will be then followed to see if there's changes, and then go back and maybe do a rebiopsy or potentially even excise an unclear lesion. So moving on to just completion of the staging workup, laboratory tests are certainly a part of it. You're going to want to start with establishing a baseline, getting a common CBC. Many of these patients will be chronically anemic. You certainly should have a baseline before you start their treatment about where they're at, their renal function, liver function tests. If they do have potential for malignancy in the liver, it's good to know where their liver function stands. And then our tumor marker that we test routinely with colorectal cancer is going to be our CEA level. Not all tumors will project this tumor marker, but we will continue to screen them post-surgery following that tumor marker, because what we know is after surgery, even though the patient may or may not have had, or may have had a normal CEA level, if they have a recurrence, we do see potential increase in CEA levels as a trigger for that more investigation should happen, that a recurrence may or may not have occurred. So CEA as a baseline prior to surgery or treatment is always part of our staging workup. And then just a little background on CEA. There are tumor-related factors that will elevate this. Advanced stage colorectal cancer, specifically with liver metastasis, will typically elevate the CEA level usually into the hundreds, or can be into the hundreds. And the reason for that is CEA is cleared in the liver, so liver metastases don't sort of bypass their first pass through the liver as far as clearance, and then which bodes a much higher elevation in the serum CEA level. Grading is actually counterintuitive. A well-differentiated tumor is more likely to increase the CEA levels as opposed to poorly differentiated tumors. So sometimes a very aggressive, locally advanced tumor may not have a very high CEA level or normal CEA level because of this biochemical change that has occurred. There are some non-tumor related factors. Smoking can give an elevated CEA at baseline or chronically after surgery. And as we mentioned, liver dysfunction, if the patient has underlying liver dysfunction, as CEA is cleared there. And there are certainly, this is not a specific test just to colorectal cancer. There are other neoplasms that can elevate a CEA level, as you see there, ovarian, pancreatic, lung, breast, to name a few. So that's part of the staging imaging is important to detect the potential for malignancy, metastatic malignancy, or even potential synchronous separate entity of malignancy at the time of diagnosis. I brought these slides a little separate. We're going to spend a little time talking about rectal cancer staging. If rectal cancer surgery is part of your practice, it is important to know about the rectal cancer staging. That's the focus on the rectal cancer staging, as we need to become experts in that as surgeons. And the pointer I have is you really need to look for yourself, and you need to know your pelvic anatomy. If you're not familiar or you're not as comfortable with these, that this is going to impact how you're going to treat these patients from an oncologic surgery standpoint and long-term care. So it's really important that you do take a look for yourself, and we're going to go into a couple of slides about why that's the case. I have this image here of which is a flexible sigmoidoscopy, and what it is a normal rectum. And these are the rectal valves. And you can see this is the lower rectal valve, the middle rectal valve, and the upper rectal valve. And then there's a diagram here to sort of illustrates that as well. And why is this important? So with your ability to identify these valves and knowing where this is anatomically, it's going to help us with our decision-making and surgical planning. What we know is that at the level of the middle rectal valve, which is here, that's generally at or about the level of peritoneal reflection. So in situations where you're making a decision about potential for neoadjuvant chemotherapy, knowing about whether or not the patient, what surgical treatment they're going to have, restoration of GI continuity versus ostomy, diversion, not needing it, knowing where you are from the height as well as in this respect to these rectal valves, even if you don't exactly know the direct height, but knowing your anatomy here is going to help us with dictating that. Also, it's good to know anterior and posterior, whether the tumor is anterior posterior based on your flexible sigmoidoscopy. A trick that you can use if you're doing this, if you're doing the flexible sigmoidoscopy, to put some water or saline irrigation, see where it's leveling out so you can get a sense of where the anterior and posterior is. Again, patient's in left lateral position. If you're doing the flexible sigmoidoscopy and where the water is layering is certainly that left lateral side, and that will help you with identifying tumor anterior, posterior. And that's if you can't put your finger on the tumor itself. If it's not low enough, you can't palpate it yourself. So going on to that exam, I kind of lead into the digital rectal exam and how important it is, especially with assessing your ability to surgically preserve GI continuity, its respect to the sphincter muscles as well as the pelvic floor. So if you are someone that does involve yourself in treatment of rectal cancer, you have to have a good understanding of the surgical anal canal. And what we see here, from the anal verge, which is here, to what we call the anal rectal ring. And the anal rectal ring is what we see is that the levators come in into the pelvic floor. It is above your dentate line. Okay, this is up from the anus, the anal verge to the dentate line is the anatomical anal canal, but the surgical anal canal, which is relevant for us as far as restoration of GI continuity, is from here to here. And as you mentioned here, I could see that arrow pointing down at where the level of the pelvic floor comes in. You should be able to palpate that. For tumors in this location, at or about this location, you have to make a distinction about the patient's function, how they would tolerate connection to that point or below that point. So knowing where your tumor is in respect to the level of the anorectal ring, whether it is truly above that anorectal ring and you have a landing zone for a potential anastomosis. Making the decision about creating a low, what we call coloanal anastomosis, is also something that's a little more complicated and outside the scope of this discussion. But again, if you're participating in treatment of rectal cancer, your understanding of this anatomy and the pelvic floor is certainly an important tool. If you are going to participate in treating this disease process. So just a little quick touch on, the evaluation of the pelvic floor. It has been looked at. I'm sorry, the rectum. I apologize. Whether we should do a rigid proctus sigmoidoscopy versus flexible sigmoidoscopy for localizing the rectal cancer, and does it really change our management? What we found is that it really doesn't change a lot unless it's in the upper rectum to rectus sigmoid, and that really comes into play with whether or not this rectus sigmoid tumor really does not typically need neoadjuvant treatment. And the upper rectum, as long as it's above the perineal reflection, it can be treated as a colon cancer would be treated. And it 1 out of 4 times really changed where the actual tumor was located at. Again, that was revisited in a different sense about flexible sigmoidoscopy, rigid sigmoidoscopy. And again, for lower tumors, is fairly equivocal. The treatment plan relatively stayed the same. As you get further around, beyond the length of where your finger can reach, the measurements and the actual identification diagnostically changed a bit. But again, from a clinician standpoint and a practical standpoint, whether you feel comfortable using a rigid proctus sigmoidoscope versus a flexible sigmoidoscope, I think it's indifferent. You get a more accurate reading with a rigid sigmoidoscopy. Rigid proctus sigmoidoscopy as far as length from the anal verge to the tumor. However, if you have a good understanding of where those rectal valves are, that's really going to be more important because you're already going to know where relatively you should expect to see the perineal reflection, and that's really going to be the trigger point. Knowing whether or not you can connect it is going to be dictated by how you have assessed the tumor in location or relationship to the anorectal ring. So, again, your understanding of the rectal anatomy as well as the pelvic floor anatomy, I think is going to be a key in someone that is treating rectal cancer surgically. So going further in rectal cancer staging, it's one of the key points about rectal cancer staging, which is different than colon cancer staging, is the assessment of local advancement. Assessment of local advancement, the recommendation is the patient has an MRI of the pelvis with contrast. That is the standard recommendation. Endorectal ultrasound can potentially still be used. It's typically only recommended in the setting where MRI is contraindicated for the patient. They have metal or something that can prevent them from having an MRI, because the quality of the imaging, the understanding of the surrounding structures related to the tumor, and the accuracy is superior, where endorectal ultrasound there is some variability. And and has fallen out of favor as the primary diagnostic tool in preoperative staging for rectal cancer. So why is this important? Well, the reason it's important is that we need to determine whether the patient has a locally advanced tumor, meaning a T3 or T4 tumor, or if there's evidence of node positivity within the mesorectum. In those circumstances, those patients are going to be recommended to have neoadjuvant chemoradiation prior to surgery. This is the standard recommendation, as it does lower the risk of local recurrence. Long-term survival, sometimes there's a little disparity about post-treatment versus pre-treatment, but function-wise, pre-treatment is superior and local control is better. So this is the standard recommendation based on the NCCN guidelines, and this is again, the way our treatment protocol is where I practice. If, again, your institution is participating in doing rectal cancer surgery, where you get the MRI is also important. There are minimum MRI specifications that are required or recommended if you're going to be doing diagnostic evaluation of rectal cancer. You need to have a 1.5 Tesla magnet strength MRI. They're recommended that you also use an external coil. The typical treatment is using an external surface body coil as opposed to an endorectal coil, which initially was used. Endorectal coil, if you're not familiar, is basically a balloon that goes into the rectum. It boosts the imaging at the local and localizes the area within the rectum. One of the reasons this has fallen out of favor is that this is an uncomfortable exam. Patient has a tumor. Sometimes you cannot get the endorectal coil within the rectum. The patient can't tolerate it, and the imaging is not going to be as accurate. We have almost exclusively transitioned to surface coils. That's what we provide here. The surface coil also incorporates using a endorectal gel enema. And by using the surface coil, they also are able to boost the imaging in the pelvic area and the diagnostic sharpness of the imaging around the wall and surrounding soft tissue of the rectum. So this is the typical recommendation from the NCCN guidelines as well. So before we get on to treatment, I think it's important that we just break down, as I was mentioning earlier, having a good understanding of the colon and rectal cancer staging. It is fairly straightforward when you look at when you break down it into the components that we are particularly interested in from a surgery standpoint. This is from the American Joint Commission on Cancer to put these staging tables together. When we sort of zoom in on that slide, what we see is just it's important for us to have an understanding about what makes a tumor a T1 to T4 tumor. When we look at the T1 tumor, what makes a polyp invasive is that it's penetrated into the submucosa. Many times people get confused by some of the language related to carcinoma in situ, which you see here, versus high-grade dysplasia. Those words pathologically are used interchangeably. They're both considered synonymous at this point. So we try to go away from using different terminology, high-grade dysplasia versus carcinoma in situ. What you can take away from that when you get a pathologic report, the pathologist has reported whether it's carcinoma in situ or high-grade dysplasia. What you understand is that it has not invaded the submucosa. For the tumor to have metastatic capability, it has to penetrate into the submucosa where the lymphatic channels are. So that's what makes colorectal cancer invasive, is that penetration into the submucosa. As it gets further on, as you see here on the left side of the screen, the right side of the screen, the tumor penetration to the muscularis propria, through the muscularis propria to the surrounding soft colonic or rectal soft tissue, and then up to the serosa or the surrounding soft tissue, surrounding organs, which would make it a T4 tumor. Again, this is going to help us with understanding what treatment regimens we're going to need. As I mentioned earlier, a T3 and T4 tumor in rectal cancer is going to recommend neoadjuvant chemoradiation prior to surgery. If the patient by imaging has a T1 or T2 tumor, neoadjuvant chemoradiation is not recommended and is not a benefit for local control in those scenarios. Touching on what is the leap between stage 1, stage 2 to stage 3, and really when you look at all these categorizations, what we need to understand as far as our treatment, what's going to happen with the treatment and educating our patients is any node positivity is going to move that patient from a stage 1 or 2 to stage 3, and the tumor itself is not going to dictate that. As we'll talk about when we get into the treatment phase, stage 3 cancers, once there is no positivity, there has been evidence of potential that's been locally or regionally metastatic, adjuvant chemotherapy is going to be the standard recommendation. And then certainly stage 4 tumor is going to be distant metastases, meaning more one organ or distant organs. So moving along, now we can get on to the discussion of treatment, and there's both surgical and medical modalities in which we're going to discuss in the treatment of colon and rectal cancer. We'll start with sort of the foundation of where we are with oncologic management, or especially oncologic surgery. If you are performing oncologic surgery in your institution, I strongly recommend that your institution participates in a multidisciplinary tumor board. The treatment for colon and rectal cancer certainly involves a team of physicians and ancillary staff, and collectively, not all patients fall into the same guidelines every time, and discussions amongst your team of physicians and staff will help give the patient the optimal treatment. And it has been shown time and again that multidisciplinary tumor boards optimize patients' oncologic outcomes over time. Taking it one step forward, rectal cancer has become very specialized, and the American College of Surgeons, through the Commission on Cancer, created this national accreditation program for rectal cancer to establish institutions of excellence when you are treating colon rectal surgery. When you're treating rectal cancer through rectal surgery. We know the complexity of rectal cancer surgery has evolved over time. Outcomes at times were not as good as we felt it could be, and I think there was a variation from how the treatment was being done from institution to institution. And we're trying to just give a high level of care to these patients, and certainly rectal cancer does bode with it a lot of potential morbidity, including ostomies, pelvic floor dysfunction. Local recurrence is very problematic. So certainly having as we mentioned, a strong support structure at your institution, as well as experienced individuals that deal with rectal cancer is something that is advocated, and American College of Surgeons has supported that. So I'm going to break down the treatments in between colon and rectal cancer a bit separately. The basic foundation for treatment of colon cancer is surgical resection, and that is in stage 1 through 3 tumors. So anything that's any tumors that are local or regionally metastatic, meaning just to the lymph nodes, as we discussed stage 3 disease, primary surgical resection is going to be offered to that patient as the definitive treatment. Standard high surgical principles are certainly enforced, especially when you are doing oncologic surgery in colon cancer, which is somewhat different than what we need to provide for benign disease, diverticulitis, ischemic colitis, even inflammatory bowel disease. And what that entails is we typically would recommend high ligation of the vascular pedicle. We typically will recommend at least a 5 centimeter margin on either side of the tumor. And if you are consistent with those two parameters, obtaining a minimum of 12 lymph nodes within the specimen is not difficult to do. And that is the standard recommendation, that there is 12 lymph nodes harvested within your specimen. We know that when we get statistically, when there is less than 12 lymph nodes within the specimen, it portends a potential for higher recurrence and lower disease-free survival. So I think that bodes to missing potential metastatic lymph nodes with smaller lymph node harvests that were not getting all of those nodes or those lymphatic channels excised at the time of the surgery. So the standard right now is 12 lymph nodes within the specimen. Discussion that leads from colon and rectal cancer is whether or not laparoscopic or open surgery is equivalent and offers the same oncologic result. It's been discussed for many years at this point, and it's been pretty well established for greater than 20 years now. Laparoscopic versus open surgery for treatment of colon cancer has shown time and time again that it has equivalent long-term oncologic results. I will at least mention that many of these studies were done by experienced colorectal surgeons. So at the initial outset of some of these earlier studies, these were people that were doing oncologic or doing laparoscopic colorectal surgery in an experience setting and then testing their results. And over time, it's become part of the training curriculum for general surgery and certainly with colorectal surgery fellowship programs, laparoscopic surgery and high quality laparoscopic surgery, and sticking to those oncologic principles with high ligation, lymph node harvest, appropriate margin resections are all being incorporated. Certainly the benefits of laparoscopic surgery, as you can imagine, are going to portend them lower morbidity, shorter hospital stay, lower wound complications. And it actually has been shown even in this most recent study in the surgical oncology at the bottom of the screen there, is their overall outcomes long-term are now showing also improved oncologic outcomes over time. So it has shown time and time again that it is at very least it is equivalent as far as their oncologic results. And now we're starting to see some long-term even benefit over open surgery as far as their survival. So just changing a little bit and talking a little more again on some technical things. We're going to start here with discussion of right-sided tumors. Right-sided tumors meaning the cecum, ascending colon, hepatic flexure. Sticking to oncologic principles, standard treatment is going to be like high ligation of the ileocolic artery. It's takeoff from the superior rectal artery. Certainly ligation of the right colic, if it is present, is typically only present in approximately 20% of people, so you may not see it. And more times than not, you won't see a specific isolated right colic artery. And then ligation of the right branch, the middle colic, is also the standard recommendation as far as oncologic treatment. Now, I will say in practice, performing a high ligation on the right branch, the middle colic on true cecal colon cancers may or may not be of significant benefit as the lymphatic channels are unlikely to traverse that far along the trajectory of the colon. However, oncologically, certainly ascending or hepatic flexure, I'll even highlight my little pointer again, the hepatic flexure tumors, you certainly want to do a high ligation of this right branch of the middle colic so that you are getting that entire lymphatic channel as well as lymph nodes that go along with it. So it is important. And then certainly the high ligation of the ileocolic artery coming along this channel, this direction. Okay. All right. So moving on to the left-sided tumors. Left-sided tumors, it's a little more complicated as far as the location and what parts of the colon eventually will be traversed. So I'll start with the descending. I'm sorry, the sigmoid in the rectum. A high ligation of the inferior mesenteric artery is going to be initially what we would recommend, and certainly in a descending colon tumor, you will need to take that left branch of the middle colic as well. For a sigmoid colon cancer, a rectal cancer, you're not going to be taking, obviously, from this imagery, you're not going to be taking these vessels here. In the setting of a rectal cancer, it is appropriate to do a division of superior rectal artery just at the takeoff as it branches off from the inferior mesenteric artery for true rectal cancer tumors. But I will tell you in practice, many times, unless this is an upper rectal tumor, your ability to mobilize the colon and leaving that inferior mesenteric artery intact for adequate reach down the pelvis is going to be a technical barrier. So more times than not, if you do not take that inferior mesenteric artery, whether you do want to preserve this left colic or not, you may be limited in your reach. And as long as the patient has an intact marginal artery that comes across for perfusion from the middle colics, I routinely would ligate the inferior mesenteric artery in rectal cancers and sigmoid cancers alike. And as I mentioned, it does pertain a better mobility of the remaining left colon, the left mesocolon, and gives you plenty of reach down into the pelvis for your primary colorectal anastomoses. So one of the more technically challenging decisions to be made is these are transverse colon tumors. What is the right amount of colon to take? What is the correct operation to do? Historically, for transverse colon tumors, transverse colectomy was done. I will tell you that what that brought, unfortunately, was a higher leak rate as you're depending on end vessel perfusion of the ileocolic and or left colic arteries, and certainly the splenic flexure is a known watershed area, and certainly lends itself to a higher leak rate when the transverse colectomy is done and the coloncolonic anastomosis is performed from the right colon to the left colon. So typically in my practice, and would advocate an extended right hemicolectomy for true transverse colon tumors, which would be a ligation of the ileocolic artery, and then both the left and right branches of the middle colic artery. And then I would preserve the left colic, not taking it from the inferior mesenteric artery. The left colic is over on this side. You preserve that left colic for a true transverse colon tumor, and then perform an ileo to descending anastomosis. And that is an appropriate oncologic resection, getting both the channels from both the left and right middle colics. And then it also provides a better perfusion and a lower risk anastomotic complications in that scenario, as opposed to transverse colectomy, which, as I mentioned, is typically discouraged due to higher leak rate and anastomotic complications. And then again, one other technical point that I'll make here on the last area where it becomes a little more problematic is how do we manage true splenic flexure tumors? True splenic flexure tumors, the discussion about an extended right hemicolectomy, which we would incorporate the ileocolic, both branches of the middle colic, and then you would also need to take the descending branch. You would also take the left colic. So that's, the ileocolic, middle colics, and the left colic to appropriately manage a transverse colon cancer if you are doing a true extended right hemicolectomy, because you need to take this oncologic or this lymphatic channel as it traverses down to the left colic to get all the lymph nodes in this basin as well as the left colic branch. So typically I do not perform that operation for true splenic flexure tumors. This is the operation that I would perform for this location of tumor, which is a partial left colectomy. It does incorporate an appropriate oncologic resection with taking the left colic from its origin off the IMA, as long as there is not peri-aortic or near the base of the IMA lymphadenopathy. Certainly you want to address that. If there are any channels that are going down that far, or are there any large nodes in that area? But typically taking the left colic at its origin from the IMA, taking the left branch of the middle colic near its origin, and that will get both channels going, both proximally and distally. You have an appropriate margin, both proximally and distally, and then the anastomosis in this situation would be a descending, the proximal transverse to sigmoid colocolonic anastomosis. And I've been successful with that in my practice, and I find that preserves a lot of colon as far as their overall function long term. It still provides appropriate oncologic resection and again preserves colon that unfortunately is not necessarily need to be taken in a situation where you do an extended right, a fairly extensive extended right, and nearly a subtotal colectomy in a situation if you decide that you're going to perform that, which I will tell you is not an incorrect technical surgery for a splenic flexure tumor to perform near subtotal colectomy with the right, based on the blood supply and the anastomosis that you're going to encounter. But if you do make this part of your practice and you're familiar with this anatomy, I think you can feel comfortable with doing that as long as you have these vessels clearly identified and you stick to those same oncologic principles. So we'll move on now to rectal cancer after we discussed all the colon cancer, some technical components of colon cancer treatment. So starting with early rectal cancers, small tumors, T1 and T2 tumors. After you've done your staging and you've proven that there is no node positivity and we've diagnosed a T1 N0 rectal cancer, this is certainly a discussion that's a bit challenging with patients, and you have to take it on a little bit of a case-by-case basis. But radical surgery or proctectomy, whether it's low anterior resection or abdominal perineal resection, is appropriate. Some patients, because it will be definitive, and it would also give you a definitive diagnosis with lymph nodes where, when the imaging is negative in the lymph nodes, there is a small miss rate. So you still have to follow those patients. If you decide to move forward with the local excision, transluminal excision can be offered in early T1 tumors, barring there is no high-risk features, and high-risk features would be lymphovascular invasion, poorly differentiated. You have to be a bit familiar with the SM criteria. SM criteria looks at submucosal invasion and the depth of invasion, as it is further in depth from the just below the lamina propria as it goes down deeper into the submucosa between SM1, SM2, and SM3. The depth of penetration goes further on to the submucosa, but has not yet penetrated into the muscularis propria, which would make it a T2. We found that those that have an SM3 in their histologic diagnosis have similar lymphatic metastases as a T2 tumor. So there's a higher incidence of lymphatic involvement, meaning lymph node involvement, in those lower depth penetration, even though it's technically still a T1 tumor as it doesn't penetrate to the muscularis propria. Again, utilizing this means that you have a very comprehensive support staff, including pathology, to buy into giving you this type of reporting, and it's not always easy to do. So we talk about it. There's literature on it about this topic, but you have to have the appropriate histologic evaluation. You have to have the pathologists that feel comfortable with, that look at these, especially GI malignancies, very closely and are willing to kind of make this part of their practice, because this is not something that you're going to get on a regular, typical report as far as SM criteria and depth of penetration. You're going to get, it's a T1 tumor, and that's about it. So many times those have to be re-reviewed if you have a GI pathologist at your disposal. Now going up to the T2 tumors and that are node positive, radical surgery and proctectomy is still going to be the primary treatment modality recommended. It will be definitive. The patient will not need neoadjuvant chemoradiation. They'll get surgery, and after surgery, would not even recommend adjuvant chemotherapy as long as the pathology also supported what your preoperative imaging had demonstrated. Transanal excision is not recommended for T2 tumors, and the reason for that is a much higher lymph node positivity. Even though there is negative imaging, there's still up to a 25% miss rate. 25% lymph node positivity in T2 tumors. So that is felt not to be acceptable and would not be a recommended standard treatment. Now, obviously, there are always going to be exceptions to the rule. There are patients that cannot tolerate radical surgery, and you could have that discussion with them if they are poor surgical candidates and they can't tolerate a major abdominal surgery, whether transanal excision for local control is a reasonable option, knowing that there's a higher risk of local recurrence and metastatic and lymph node involvement at the time of the diagnosis. So again, this portends a multidisciplinary discussion with your team of physicians and potentially even your colleagues about, on a case-by-case basis, with some of these more challenging rectal cancer tumors, and what is the right thing for the patient. And each patient is going to have some individuality. It's not always going to fall under the criteria of the NCCN guidelines. but these are the standard recommendations just coming out as as a baseline understanding of what is recommended and not recommended. So as we get to a more locally advanced tumor state, and this is what we see more often than not, is that the patient has a locally advanced tumor. So that means a T3 or T4 tumor, or there is node positive findings on the MRI or EUS, if that's what the staging, local staging that has occurred. And that standard recommendation, as we discussed earlier, is going to be neoadjuvant chemoradiation, and then surgery after the treatment of radiation and chemo. We know that this lowers the local risk the risk of local recurrence. I think it's important to have an understanding about what the treatment is, because your patients are going to ask you, "Oh, I'm going to get radiation. How long is it going to be? What does it mean?" So you're not going to have all the nuances or know all the nuances of radiation treatment, but it is good to have a baseline understanding of what the treatment is going to be. And typically, the standard recommendation is going to be what we call long course radiation therapy, which is typically 45 to 50 gray of pelvic radiation, and that's typically given over 5 weeks. It's given concurrently with 5-fluorouracil, or it also can be substituted with oral capecitabine, which is Xeloda, which is broken down into, it has the effect of 5-fluorouracil. Again, that's also dictated individually many times by your oncologist, whether they're going to pursue 5-FU versus oral capecitabine during the neoadjuvant portion of their treatment. And then following the completion of their chemoradiation, most standard surgical recommendation is that approximately 6 to 8 weeks following the completion of radiation would offer that surgery, which would, whether it's a low anterior resection or an abdominal perineal resection, depending on the location of the tumor, that's when that time frame will occur. There is certainly data to suggest stretching that rest period out beyond that 8-week interval, 10, 12, I've seen even 14 weeks. And many times that I may incorporate a little bit longer period of time of interval for tumors in which I am concerned about a threatened margin or an encroaching presacral fascia or an anterior prostate margin, to allow the radiation effect to have a little bit longer duration and to see if there's more regression of the local tumor. I do not routinely get post-treatment MRI to reevaluate the tumor. I would say that in a situation where I am worried about a threatened margin or a potential second organ involvement, whether it's vaginal wall, bladder, prostate, or posteriorly to the sacrum, I may get a post-treatment MRI so that I'm prepared for whether or not there's going to be more extensive involvement. Has this patient had an effect with radiation regression of the tumor to the point that I have an understanding of what that margin is going to look like and what subspecialty involvement I may or may not need. I want to touch on just briefly, so you're familiar with it, there is an alternative treatment to long course chemoradiation, and that's short course radiotherapy. It's given more commonly in the European countries as part of their treatment protocols. It's not as utilized in the United States. It is used in certain centers. We do use it occasionally on a case-by-case basis, and it is in the protocols for guidelines. And it's given without chemotherapy. Short course radiation is given over a 1-week period, typically 25 gray, and so higher dose and given in 5 fractions. And it's a shorter interval to the time of surgery, most in the initial guidelines and recommendations. It's usually given on over a 7-to-10-day period of time, and then after you completed the radiation treatment, after 7 to 10 days, you take that patient directly to surgery to do the operation. You can wait 6 to 10 weeks, and that's in those situations where you're not worried about a threatened margin. For one reason or another, the patient could not endure long course chemoradiation, but they wanted to get the treatment, then they could do short course and then do a standard long wait and then come back for surgery. But the standard typically is if you do your short course radiation, that the surgery is going to occur within a week to 10 days following that completion of short course. Again, we typically implant this for select cases and is not standard across the board. And I typically do avoid it as I mentioned, with a threatened margin, I prefer to give long course in those cases, but there are some specialized circumstances where you cannot offer that. Moving ahead to some of the technical components, rectal cancer surgery, we typically recommend a mesorectal excision. That's the standard recommendation if you are doing oncologic surgery for rectal cancer, and that's preservation of the mesorectal fascia. It's also going to incorporate a high ligation of the inferior mesenteric artery. We did comment on it is appropriate to do a ligation of the superior rectal artery or the superior hemorrhoidal artery at the takeoff of the IMA by oncologic principles, barring there's no abnormal lymph nodes at the base of the vessel as a takeoff from the aorta. But again, if you're doing this routinely as a surgery, I will tell you that when you do not ligate that inferior mesenteric artery at takeoff, ultimately you sometimes are limited in your mobilization of the mesocolon on the left side as you're bringing it down to make your colorectal anastomosis. So it doesn't, it may, taking the ligation at the superior rectal or superior hemorrhoidal artery is maybe technically appropriate, but may technically limit your ability to do the connection down below. We still typically recommend a 5 centimeter margin. That's for upper tumors. As you get into the middle to distal rectal, 2 centimeter distal margin is appropriate. However, we can accept a 1 centimeter distal margin or even less if you're trying to preserve continence and a very low lying tumor and you're approaching the anal rectal ring and considering a hand sewn cholanal anastomosis or cholanal anastomosis, a negative margin in that scenario is acceptable. But beyond that, we typically want at least 1 to 2 centimeters of a distal margin for rectal cancer. Looking just briefly at this sagittal image, again, your surgical plane is going to be here. There's the presacral fascia. It's going to get you into that TME plane behind the rectum. Anteriorly, this is the anterior reflection, the perineal flexion. You're going to be coming down through this plane. Then the DVF is done Denavier's fascia. And in the male, if there is an anterior tumor, it's typically recommended you try to take that Denavier's fascia as part of your specimen as you're getting down for certainly these mid to low rectal tumors in an anterior plane. Again, having a good understanding of your pelvic floor and your respect to the sphincter muscles and pelvic muscles is certainly part of your treatment and what your ability to offer such treatment in these rectal cancers, specifically mid to low rectal cancers. Laparoscopic versus open. Again, a big discussion about that leading up to this point, up to this paper that came out in 2015 in JAMA. Laparoscopic open equivalent non-inferiority and how it had been discussed and debated on multiple levels. This was the first time in a paper that they looked at just the pathologic outcomes. Dr. Fleshman and that group, when they published this paper, actually showed that open surgery did a slightly better job with their oncologic principles regarding distal and circumferential margins than laparoscopy did. Did not really pretend the long-term oncologic effect or survival benefit, but it's looking strictly at the technical components associated. Now you can extrapolate that when you do a better technical operation, they have better oncologic operation or better oncologic outcomes. But again, in this paper, that was the one paper that had stood out and was a well-done randomized controlled trial of a large population of patients that actually did not show the laparoscopic surgery was even. It was a non-inferiority study. And since then, people have challenged it. They've looked at it again and again, and really they as recently as the Annals of Surgery this past year showed that looking back and collectively, we have not been able to demonstrate that it's inferior. And I think, again, it goes to experienced hands, experienced surgeons that do laparoscopic rectal cancer surgery. I will tell you in the Fleshman paper, these were experienced surgeons as well. But the bottom line is it's too close to call. I think the benefits outweigh the risks. But again, you have to be comfortable in an operation. And I think realistically or in true practice, if you're not comfortable with laparoscopic surgery during rectal cancer, but you are someone that does it routinely in your practice, open surgery is not inappropriate or a failure as long as you're sticking to oncologic principles as far as their long-term outcomes. Moving on briefly to just some adjuvant treatment. Stage 3 disease will all typically be recommended adjuvant chemotherapy. Certainly there's a lot of variability from patient to patient about what they can and cannot tolerate. But I will tell you the standard recommendation is going to be what we call Folfox, 5-F-5-fluorouracil, oxaliplatin, and leucovorin. There are some other derivatives, again, outside the scope of our discussion today, but just be aware of at least Folfox is some understanding about what typically the patient is going to get in an adjuvant setting. They will consider adjuvant treatment in a high-risk stage 2. I think that's case-by-case basis. There's not clear recommendations on that. I think that's, again, a discussion for your multidisciplinary tumor boards. High-risk stage 2s, obstructing tumors, T4B, meaning involving a second organ, high-risk features, signet ring, mucinous, poorly differentiated. These are all features that one might consider in a younger patient with this high-risk tumor, should they also be offered adjuvant chemotherapy, even though the risk-benefit may be still marginal. I think at least a discussion or at least an evaluation by oncologists with the patient as well as a tumor board conference is appropriate. Not going to spend too much time talking about stage 4 colorectal cancer. It's a very large, complicated discussion. Certainly, it's a multimodal treatment. Surgically resectable disease is possible and does show increased survival, whether it's liver and or lung resection that can be part of that treatment regimen. Systemic chemotherapy is still the cornerstone and typically is an initial stage in treatment as once the patient has stage 4 disease, they have what we consider systemic disease. Certainly, going straight to chemotherapy in those scenarios is most times than not advocated unless there are symptoms barring you from going straight to chemotherapy related to the primary tumor. Of course, obstruction, ongoing bleeding, those may mandate us going forward with dealing with the primary tumor and then addressing the other issues in a stepwise fashion. Just briefly on a little bit of survival statistics, again, of the NCI statistics. As you can see from the graphs here, stage 1, stage 2, which we consider localized disease versus stage 3 disease, regional disease, and distant disease. The majority of the patients that fall under this scope, almost 90% 5-year survival in our stage 1, stage 2s, which have local disease. There is a bit of a drop off, almost 20%, when they have local metastasis to the region, to the lymph nodes, and the 71% survival. Stage 4 disease is a significant drop off. Once that they have spread outside the regional lymphatic channels and out into other organs, the 5-year survival is less than 15%. And that's with additional treatment, and this is all comers. So there are some that do not pursue treatment here, but that being said, it's certainly a significant drop off. So again, this bodes back to our prevention and early detection through screening, how important that becomes and what a difference it can make in these patients as far as their survival if we can get to them before they have a cancer or certainly early in its evolution. And the last bit of the discussion will be, I'll spend a few moments on anal cancer. Anal cancer is a sort of a separate entity. It's a different histologic diagnosis, and its natural history is much different than colon or rectal cancer. It's squamous cell cancer of the anus. There is a bit of a distinction between anal margin versus anal canal. Anal margin is from the anal verge to the 5 centimeters surrounding the hair-bearing area around the perianal skin. The treatments are different. For an anal margin tumor, it's treated with local excision, as opposed to anal canal cancers, which are the primary treatment modality is going to be chemoradiation, as long as it's locally advanced and not systemically advanced. And so it's important to be able to, again, understand your anatomy, where the diagnosis is, where the tumor is, and that will help us in deciding what is the appropriate treatment. In the red arrow, you see that letter C, that's a tumor that's within the anal canal, and then letter D is a perianal skin anal cancer, and that letter C is going to be chemoradiation. Letter A is going to be typically treated with local excision. Again, and that's in the setting of not distant metastatic disease and locally advanced disease. Risk factors for anal cancer. Exposure to HPV is certainly the most critical of them all. HIV positivity and certainly anal receptor intercourse. Homosexual males have a higher incidence and increased risk of anal cancer. So screening and identifying these patients that are at risk and looking is part of it. And there are programs, especially infectious disease programs, where they have HIV testing, especially in homosexual males, that they're doing annual Pap testing of the anus, just like the way they would do Pap testing in the cervix, to detect dysplasia and detect, and potentially eradicate and or identify anal cancer early in its evolution or before it evolves. There has been a steady increase slowly over time. I suspect that we are hoping that with the advent of the HPV vaccine, that this number is going to plateau and start to decline as there's more broad acceptance of the HPV vaccine and ultimately prevent both cervical and anal cancer. Evaluation is typically done with local evaluation with endoscopy and biopsy. You do need to perform an inguinal exam to check the lymphatic channels, as it very commonly will spread to the inguinal lymph nodes, and there will be inguinal lymphadenopathy. All patients, whether they are involved in high-risk sexual activity or not, should be HIV tested. Any female that has a diagnosis should have a pelvic exam to look at the cervix and test for cervical dysplasia. The standard staging is going to still be CT scan, chest, abdomen, pelvis, but we'll tell you in practice, PET-CT is typically utilized as they're looking for increased activity in the inguinal canal, which is not always picked up on CT, and that will help with the radiation oncologist with determining how they're going to drive the radiation treatment. The inguinal lymph nodes will be radiated in addition to the anus as far as the treatment, but if there is known clear positivity of the inguinal lymph nodes, they will give a boost or an increased dose to the inguinal lymph nodes as part of their treatment regimen. I don't routinely do MRIs, but you can consider it if it's a very large, bulky tumor. You're worried about direct invasion as far as other tumor or other organ involvement, prostate, vaginal wall, that sort of thing. And it's good to start with a baseline before you initiate treatment. That way, you'll have a sense of whether or not the patient's going to recover from treatment, and then if they don't, what may or may not be required. As I mentioned, standard treatment is chemoradiation, which is mitomycin with 5-fluorouracil or capecitabine. And radiation is going to be to the anal canal as well as the inguinal region. And that's about on that. The follow-up is going to, typically I would see these patients at 8 to 12 weeks after completion of their chemoradiation to assess for response. If there is residual disease there, it is not a failure. That is not considered a failure of treatment. We can have continued regression disease up to 6 months following completion of the radiation treatment. If over the course of the follow-up period you see that there's a failure of resolution or potentially there's no regression or there is progression, then you would kick the patient back. Or certainly at 6 months, if there is certainly still disease there or an ulceration you're still concerned about, then it would take that patient for diagnostic evaluation and biopsy that to see if there is truly residual disease. Because unfortunately, residual disease typically equates to salvage resection or abdominal peritoneal resection with permanent colostomy. We must restage those patients to rule out any disseminated disease at that point. And if it is a recurrence and it's just in the inguinal nodes and the anal canal is still healed and it's just no disease, you can locally treat just the inguinal recurrence. And after that, that's the sort of the last slide I have. I will just add to that colon cancer is a highly treatable and preventable disease. Certainly a robust screening program in your community and in your facility is important. Encourage your patients screening to all, encourage screening to all your patients, and knowing these younger patients that are higher risk that should start getting screening earlier is important. You may be seeing them for other reasons, as a reason to go and get them screened. And then on a separate note, anal cancer surveillance, certainly in your high-risk patients, if you're seeing those patients with anal condyloma, HIV, we should be evaluating them because you can also prevent anal cancer if we're detecting dysplasia in the anal canal earlier in its evolution. And that's the conclusion of my talk. Thank you.